And Dr. Heder, if you go down to the bottom, it looks like an open book. If you click that, it'll take it to presentation mode for you. Bottom right-hand side of the screen. Over to the left. It looks like a little icon, like a textbook that's open, a little image.
Okay. Yeah, let's see here. Can you guys see my slides?
Yes,
Yes.
that's perfect.
Okay. All right, perfect.
Thank you.
Yep.
All right, very good. All right, so the topic that I want to discuss today is, I feel it's kind of an ignored topic. We really don't think much about it, although I think it's very important. And this is the association of diabetes with the liver issues, or the non-alcoholic fatty liver disease, or it's called NAFLD, so non-alcoholic fatty liver disease. So diabetes, obesity, most these patients are at risk for developing liver problems. So that's the reason about discussing this topic. And I think if we develop an approach about screening these patients for this problem, and talking to them about preventing this problem, liver problem, from happening, then I think we can help our patients and their diabetes in the long run. So that's the reason for discussing about this topic. All right, so this is what I want to do in the next maybe 20, 25, 30 minutes, is to develop a strategy as to which patients are at risk of developing this NAFLD, which is the non-alcoholic fatty liver disease, and NASH, which is just an exaggerated version of fatty liver, where actually there is inflammation. So it's called NASH, which is non-alcoholic steatohepatitis. So now there is inflammation in the liver, and the fatty liver is progressing. And then how should we manage? How should we prevent this from happening, number one? And then how should we treat if they already have NAFLD or fatty liver developing? And then some of the treatment options that we can offer these diabetic patients and non-diabetic patients to help with these problems if they're already developing fatty liver or NAFLD or NASH. So that's what I want to achieve over the next 30, 35 minutes. All right, I'll start with the case. This is a real case, a clinic case, and it's a common case. I'm sure all of you have seen these cases as well. So let me see, this is, all right, good. So I'll describe the case first, and then we will talk about the management and the outcomes a little later. So a 69-year-old man with the history of type 2 diabetes, who has been experiencing some discomfort, vague discomfort on the right upper side, which comes and goes. He's really kind of vague about it. He's just brought it up during your clinical visit because he's bothered by it. You're seeing him, or he was seen in the clinic by me for diabetes, which was diagnosed more than 10 years ago. He also has other metabolic issues like hypertension and hyperlipidemia. So this is your class, your typical patient that you will see in the clinic, and we normally see these kind of patients all day long. His medications are Metformin, 1,000, twice a day. He's on lisinopril for blood pressure control and a statin. And this is his first visit. He's just coming to establish with an endocrinologist. He has family history, which is significant for diabetes in his sister and also mother, and prostate cancer in the father. He also shows you a copy of the ultrasound, which was ordered by his PCP because of these vague complaints, and to evaluate for this right upper quadrant discomfort, which is showing the ultrasound report, and you only have a copy of the report during the encounter. And with the radiologist actually comments about clinical suspicion for steatohepatitis, which is NASH, and clinical correlation required. So that's what you're seeing on the ultrasound, or at least that's what the report is saying. And on examination, the important thing is his BMI is 35. So that's the moderate obesity or stage 2 obesity. You also have labs sent to you by the primary care physician. So you have an ultrasound and the labs. The blood sugar on that blood work on a BMP is 127. A1C is decent, 7.5. The liver enzymes were also done, and rightly so. The ALT is 52 and AST is 39. I will come back to that a little later because these are in normal ranges, by the way. they are not high. Albumin is 3.5, platelets are slightly low, but not extremely low, like they are on 132, 132,000. LDL cholesterol on a statin is 110 and triglycerides is 290. All right, so this patient, based on the ultrasound, has steatohepatitis, according to the report. So what is fatty liver, and what is this association with diabetes? I find this very useful. This picture very useful. So if you see here, these are your adipose tissues. These are the fat cells present in the body. This, of course, is your liver. When patients are gaining weight and they are developing insulin resistance because of the weight gain over a period of time, insulin will not work on these adipose tissues or these fat cells. The job of insulin is to make sure that these adipose tissues pick up glucose and prevent the release of these free fatty acids. So that's what one of the functions of adipose tissue is to take up glucose and prevent and store basically triglycerides and fat. So if you have insulin resistance because of weight gain, then the glucose will not be picked up by these adipose tissues. And at the same time, these adipose tissues will start releasing these free fatty acids into the bloodstream. So they are releasing it. Normally they will store it, but and they do so because insulin signals them to store it and pick up glucose. So now, because the body is developing insulin resistance because of the weight gain, these free fatty acids will be released by these adipose tissues into the circulation, and they will be picked up by the liver. So basically, the storage form, which is the adipose tissue for these fats, is no longer storing it, and they're coming and getting stored into the liver. And because they're in the liver, so they will start, initially they will just cause fatty liver, basically fat in the liver, and eventually it will cause some damage to the cells, to the liver cells. And that is where the steatohepatitis or inflammation will start to take place. If this continues over a period of time, this is where cirrhosis of the liver or permanent damage of the liver will develop. So NAFLD, or the fatty liver, will convert into steatohepatitis, will eventually convert into cirrhosis without any other agent. They're not drinking, it's not alcohol related, it's not gallstone related, it's just the fact they're developing insulin resistance. So if we can help our patients here before these adipose tissues start releasing free fatty acids, and before this damage, permanent damage happens, we can actually help these patients. And obesity and diabetes is one of the risk factors, because if we look at the other half of the picture is, if the patient develops steatohepatitis, their insulin resistance because of inflammation, anytime there is inflammation in the body, for any reason, because of infection, gingivitis, rheumatoid arthritis, any inflammation will increase insulin resistance. If the insulin resistance increase, then their blood sugars will be higher. High blood sugars will eventually lead to worsening of diabetes, of course, and it will in turn worsen the liver disease as well. So a benign process, which is insulin resistance because of the weight gain, initially leads to free fatty acids, which causes hepatitis, steatohepatitis, or fat-induced inflammation of the liver, which in turn will make the diabetes worse. And this will become a vicious cycle. So one making the other worse, and over a period of time, the patient's liver and diabetes will suffer. So we need to stop this process where the free fatty acids are getting released from the adipose tissue. To put it another way, we have to prevent the insulin resistance, prevent the patient from developing insulin resistance. This is just a diagram to understand what are the stages. So this patient here, if you look at this part of the picture here, they have normal glucose tolerance and no fatty liver. But as this glucose increases over a period of time until they develop severe diabetes or hyperglycemia, their liver disease will progress as well. And again, this just shows the association between the two. The blood sugars are increasing because of inflammation, and their liver disease is getting worse. And this starts to happen much long before they're actually diagnosed with diabetes. So most of these patients are just obese, they're healthy, they have, otherwise they have no issues, their blood sugars are okay, maybe they're borderline diabetics, And that's why we screen patients for diabetes early, especially if they have obesity, especially if their family history risk factors, because we can identify these patients and can prevent the fatty liver from developing. So as their as they're gaining weight, their insulin initially will try to, their pancreas will initially try to make more insulin. And eventually the beta cells, which are making the insulin, will eventually start to fail. So if you see this red line here, the body, the pancreas are trying their best to make more and more insulin to overcome this resistance. At the same time, the fatty liver is getting worse, but there will be a point in time where the pancreas cannot release any more insulin, and that's where the beta cell failure is happening. So when you see these patients here, they have diabetes, they're needing insulin, their fatty liver has already worsened, and some of the damage has already started to take place in the liver, and their health is compromised. So the bottom line here is, the take home message here is, we need to identify these patients early. Obese patients, strong family has history, screen them, counsel them about obesity, and we will talk about the management here. So identification is the most important thing. So what in, these are just the histological slides just to emphasize on this point. This shows fat in the liver. So this is your NAFLD or the fatty liver. So you see these clear cells here. These represents the fat cells which are released by the adipose tissues, and they are getting accumulated in the liver. Over a period of time, this is the progression. There is hepatitis or inflammation. So you see there's some damage and some macrophages accumulating. And over a period of time, if we cannot stop it or if we don't treat it well, this is the end result, which is cirrhosis of the liver. And now you see that the same entire liver tissue has shrunken into a small fibrous mass. So this is what we're trying to do, we're trying to prevent. This just shows the same association that NASH, diabetes, will make the steatohepatitis and inflammation of the liver worse. And because of inflammation, the diabetes will get worse. You will see a lot of patients who are requiring a lot of insulin. So we have to think about what else is going on. Is it they're not taking the insulin? Is there some form of inflammation? Or is it their liver which is also contributing to it? So maybe scanning the liver, checking the liver enzymes, and we will talk about this. So one will make the other worse, and then it becomes a vicious cycle, and both the processes will continue to worsen over the period of time. All right, so the most important thing here is, and now we're coming to management, is to prevent this from happening. So identify, diagnose, and then prevent. So if you have a patient who is obese and you're falling in the clinic, and we want this the fatty liver, we want to prevent this fatty liver from happening. So this is the mainstay that we can tell these patients, and the most important thing will be weight loss, because weight loss will help the insulin resistance. That means that the free fatty acids will not be released by the adipose tissues. So that's the most important thing. And the second thing we can do to prevent this from happening is cardiovascular risk management. So if they have hyperlipidemia, high cholesterol, high triglycerides, that needs either treatment, either counseling with diet and exercise, or treatment in terms of medications. Hypertension is another big player which can make this NASH or liver problems worse. And if they already have diabetes, then controlling diabetes with appropriate agents, and we will talk about these agents. So weight loss and their metabolic risk profile, which is diabetes, hypertension, and glucose needs a treatment. So these are the blood pressure targets for diabetic patients. Ideally, we should target a blood pressure of less than 130 systolic and 85 diastolic. So that is our target. However, if we have a patient who has diabetes and their blood pressures are running more than 140/90 consistently at home and on visits, then in addition to the lifestyle, which is weight loss, diet, and exercise, we should consider initiating medications or pharmacological treatment to achieve our target, which is less than 130/85. So if you have a patient who is on a couple of visits, blood pressures are more than 140, home blood pressures are running high, they've already tried the diet and lifestyle, that is a time to intervene and consider starting blood pressure medications with weight loss, diet, and exercise. And these are the recommendations from ADA. So if you have a patient with very high blood pressure, so systolic more than 160, diastolic more than 130, so in addition to lifestyle, which is your weight loss and stuff, we should think about starting dual therapy or a combination of medications like for example, an ACE and a diuretic, because again, our target is 130/85. So we have to be aggressive if their blood pressures are running higher. So if the blood pressures are very high, we need to be more aggressive and of course follow these patients closely. But the most important thing is weight loss, diet and lifestyle. And these are some of the agents that we use, and I'm sure most of you are very familiar with these. These are your ACE inhibitors, so medications like lisinopril, angiotensin receptor blockers, so your losartan, Diovan, these kind of medications. Thiazide diuretics are also a good agent, and as long as you keep an eye on the potassium, and your medications like Norvasc or amlodipine or felodipine, which are dihydropyridine calcium channel blockers. Most patients, like I said, may require combination therapy, which is an ACE or a diuretic. We should not mix ACE and ARB together because of the risk of hyperkalemia. They will increase the risk of potassium problems because they may make you retain potassium. So those are some of the agents that we can use to achieve our blood pressure target. Lipid lowering therapy, or which is the cholesterol management. There is a scale that you can download from ACE American Cardiology website to calculate the risk for atherosclerosis in these patients. And you put in all these information, their age, the smoking history, if they have diabetes, if they have hypertension, and this will give you this score, the risk of cardiovascular disease over the next 10 years. And we use this score to decide what dose of and what agent to use for their lipid lowering therapy. So mostly any diabetes, any age, if the patient has already had a cardiovascular event or a stroke or heart disease, then they need high intensity statin, which is your rosuvastatin and atorvastatin higher dose, so 40 and 80. So if they already have an established cardiovascular disease, they need a high intensity statin. Any diabetic between the ages of 40 and 75, and if their risk, 10-year risk is more than, based on that scale, is more than 7.5, then they also need a high intensity statin because they're at high risk for developing problems. So again, this is rosuvastatin and atorvastatin. If they're diabetic in these age groups between the ages of 40 and 75, and however their risk is less than 7.5, then we can use a moderate intensity statin. So that means you can use atorvastatin lower dose, 10 or 20, or your simvastatin or Pravachol or pravastatin. All these others are moderate intensity statin. And any diabetic with the age more than 75 and no cardiovascular risk, then we can also use a moderate intensity statin, so low dose atorvastatin and stuff. So this is important to calculate because most of our diabetics, as you can see from here, will need a statin, and they should be on a statin. This will not only help their cardiovascular disease, but will also help in the development, preventing the development of fatty liver. Some patients, if on the statins and their cholesterol is still more than 70, and then other agents can be added. So ezetimibe can be used, which is your Zetia. And in some patients, if they're taking a statin and their cholesterol is still high, then PCSK9 inhibitors can be used to bring these numbers down. But the bottom line is we have to control, we have to prevent them from developing high, abnormal lipid profile and keep their cholesterol less than 70. So the major I see two challenges here when we are dealing with these patients. One is we don't have, I'm talking about the fatty liver. The main problem is we don't have good tests that can identify these patients unless and until we are doing scans of the liver, ultrasound, or other scans on a regular basis. These patients will be underdiagnosed because, as you see here, these tests that we do, the AST and ALT, they have very low sensitivity for identifying the early stages of the disease. So if the patient has fatty liver, now liver is a very robust organ, and it can regenerate, and it is a big organ. So unless and until there's significant fatty liver that has developed, these patients will not show any abnormal lab tests. Their ALT, their AST will be normal. Even in the early stages of this fatty liver, their liver ultrasound will be completely normal. And unless you're using MR scans or MR, magnetic resonance stereotactic imaging, which we normally don't do, they are not covered, they are expensive, we will miss these patients. So What we need to do is to use a high index of suspicion for these patients. So if they have they have obesity, and we are concerned about insulin resistance, meaning they have acanthosis nigricans, which is the thick velvety skin on the side of the necks, or the increased pigmentation around the neck, or skin tags, we should alert these patients about potential liver problems and start treating them with lifestyle and with diabetes, with their blood pressure management, with their cholesterol profile, and also with their diabetes control to help to prevent them from developing fatty liver. And the other major challenge is there are some good medications, good diabetic medications, and we will talk about them here in more detail, which are actually quite helpful for these patients for liver disease or fatty liver. But these agents are not used as much in clinical practice because of some concerns, and we will talk about these. However, there are new medications and new options that we can try for these patients, and that is why I decided to talk about this here. So the diagnosis: how should we diagnose these patients with the fatty liver and with NASH? So one thing is, like I said, AST and ALT are not very helpful, but they can give you a clue. The clue is here is this. So if you have a patient with normal AST and ALT, but the ALT is clearly double or higher than the AST, then this indicates, so ALT represents the liver hepatocytes, so the liver tissues. And AST is basically the mitochondrial cells. So if you have a patient where the enzymes are normal, but the ALT is clearly higher, almost 2 times, 3 times that of AST, these patients, this will tell you that there is some sort of injury or inflammation or a process going on in the liver. So that's one thing. However, I must tell you this: AST and ALT, even in patients with NASH or fatty liver, will be normal. So I think this is where looking at these ratios, ALT and AST ratio, will be helpful when you get a CMP or a liver panel. The other thing is, these patients, if you have any concern and if you see this pattern, if they're complaining of any right upper quadrant pain like this patient was, I think it's a good idea to start with any imaging study. Ultrasound is, you just use a sound wave, so there's no radiation exposure. That's a good study and it's well covered by the insurances as well. And we always ask about the alcohol consumption history, because if they are consuming alcohol, we have to take that into consideration. Is that expediting the process of their liver damage? And also exclusion of other liver problems, your hepatitises, and if they have hepatitis C, so just asking about it, see if they have already been screened for B and C and any other liver problems. So using the ALT to AST ratio, if you have high index of suspicion, then maybe doing an ultrasound is another option. So we talked about prevention, which was weight loss and lipid and diabetes control. Now, what are the treatment options? And I think this is important. So weight loss is the cornerstone again, not only for preventing these conditions, but also treating these. If you have a patient with just fatty liver, meaning there is no inflammation, so the liver ultrasound is just showing some fat deposition, yeah, they have some fatty liver, weight loss, any weight loss will help it. However, they are required to lose, if they lose about 5% of their body weight, so if they are, say, 300 pounds, that will be 15 pounds. Their fatty liver, it will help their fatty liver. However, if they are developing, NASH, or which is hepatitis or fibrosis, early stages of fibrosis, then 10% of the body weight loss will help reverse it actually. So that 10% is about, in a 300-pound patient, that will be about 30 plus pounds. So weight loss, and giving patients these targets as to how much they need to lose. And of course, this will also help their diabetes, their sleep apnea, and everything else that they have. So this will be a very good recipe for their liver to help. The other thing is the exercise will indirectly help fatty liver as well. Even after exercise, they are not losing weight, because it will mobilize these fat deposition from the liver. So moderate intensity exercise, 150 minutes or about 3 hours in a week is recommended for this to help reduce the fatty liver. In terms of diet, most patients ask about the diet as to what's the best diet. So the diet that is actually seemed to help these patients is the Mediterranean diet. And that is the recommended diet for patients who are at risk for developing the fatty liver, or they have already developed the fatty liver. So weight loss, exercise, and changing their diet. And the preferred diet here is the Mediterranean diet. Now the treatment options. So this medication, I'm sure all of you are familiar with this medication, pioglitazone. So this medication is very important, and actually it can help the patients. And we will talk about what are our concerns when we are talking to patients about giving them these medications. So we have looked at this picture before. So if you think about this medication, Actos or pioglitazone, was initially marketed to help the triglycerides. It was not a diabetes medication. In the clinical trials, it was studied for high triglycerides. So the way it works, it increases these adipose tissues. It increases the size of these adipose tissues. So it makes them more healthy. So if in patients with the fatty liver, the problem is they're developing insulin resistance, and they're releasing these free fatty acids. So what it does, it increases these adipose tissues. So now they can take up these free fatty acids and retain these free fatty acids much better than before. So over a period of time, these adipose tissues will increase in size, and these fat cells, which are getting deposited in the liver, will be actually picked up, and that's how it reduces the insulin resistance. So because the free fatty acids which are causing inflammation in the liver, this will go down over a period of time. So this medication actually has shown improvement, and it acts on all three stages. It helps with the fatty liver. It actually helps with hepatitis as well. So if you have a patient who has already developed hepatitis, fat-induced inflammation in the liver, it will help it. And in the early stages of fibrosis, so they are starting to develop cirrhosis. But if you start this medication along with the weight loss and hypertension and lipid profile management, it will help reverse it. And this has been proven with the biopsy. So if you do the biopsy, there will be improvements in these patients. The doses that at which it helps these three processes is, so the Actos comes in 15 milligram, 30 and 45 milligram. The doses where it's most beneficial is the 30 milligram dose and the 45 milligram dose. So that's the dose to start these patients on. However, there are some concerns for Actos. Number one concern, I think we need to discuss this with the patient, is the weight gain. So on average, these patients gain about 3 kilograms. Now, this depends on how much they're eating and what are their how much they're exercising. So 3 kilograms means about 6 pounds, 7 pounds, actually, 7 pounds. So if they are doing exercise and they're trying to lose weight and they're watching their diet, then this effect they can offset some of these effects. And this is not from fluid. This is actually the fat cells they're depositing. And the weight gain is mostly in the gluteal area, in the thighs is where they're accumulating these adipose tissues. So that's where most of the weight gain will be. So that's one concern. The second concern is it can cause fluid retention, and in patients with congestive heart failure, already established congestive heart failure, or unknown diastolic heart failure. If you give them Actos, then they can develop fluid retention. They can start having some problems breathing at night. So if you start these medications, you tell the patients if they're developing fluid retention or if they start having any problem breathing when they're laying down in bed, they need to update the provider. There is some concern about bone loss, especially in women. It can cause osteoporosis over a long period of time. So that is another thing. If you are starting using this medication in an elderly patient, then besides congestive heart failure, weight gain, bone loss is something, or osteoporosis development, that is something that can happen. There are some association with bladder cancer, but really we are not 100% sure if this is just a correlation or this is a real risk with this. So when we are starting these patients on Actos, we always talk about weight gain, congestive heart failure. If they already have congestive heart failure, that may not be a good option. And in the appropriate setting in women, elderly women, if we are deciding to start this medication, then bone loss is another thing. Compared to Actos, this probably is a much better agent, the GLP-1. So these are your weekly Ozempic or daily Victoza injections, Trulicity. These are some of the agents. So the advantage of using this medication is, unlike in Actos, there will not be a weight gain. They will actually lose weight. And this medication has been studied. Victoza, of all these agents, have been studied the most in this setting of NASH and fatty liver. And just like in Actos, it can actually reverse some of the changes with hepatitis and early stages of fibrosis. So this is a very, very good agent with other benefits as well, which we will discuss here. These medications are well tolerated, other than some gastrointestinal side effects. Most patients will feel nauseous. So we always ask these patients to eat slow, bite, let it go down. As soon as they're full, they stop. Otherwise, they will be nauseous. So, and especially in the first 2 to 3 weeks, they have to be very, very careful. Bite down, let the food go down. As soon as they're full, they need to stop. There is some, again, risk of pancreatitis and pancreatic cancers. However, I'll tell you this medication has been available in the market, this class of medication, since 2005. So we have about 17-year data on this medication. And most of us, most endocrinologists are, after carefully reviewing all this data, we do not feel that it causes pancreatitis. Diabetes and obesity can cause pancreatitis by itself. So sometimes the patients may be on this medication and they develop pancreatitis. That most likely is not related to just the GLP or a Victoza or an Ozempic. They have other risk factors. They have diabetes, they have obesity, which can cause pancreatitis. So just because of, if you're not starting the medication just because of this risk of pancreatitis, then I think we are depriving our patient of a very important agent which can help them actually lose weight and also NASH. So I'm not concerned about patients developing pancreatitis when I start these agents. Now, if a patient already has had multiple episodes of pancreatitis or strong family history or personal history of pancreatic cancer, I will not start this medication just as a precaution. But otherwise, it's a very good medication. Now, what about metformin and fatty liver? This is a common agent. Most patients are on it. Like when we were talking about our patient, he was already on metformin. So metformin will reduce the fatty liver, will prevent it because it's weight neutral, will help it. But if the patient has developed NASH or inflammation has started or fibrosis has started, unlike Actos and unlike your GLP agents, there are no proven studies to show that it actually helps. So if you have a patient on metformin, we can continue it. It will not harm the liver as long as the kidney functions and GFRs are okay. We can continue that as long as they're tolerating it. But just expecting metformin to solve that problem, especially if they have NASH, like our patient had, will not be enough. So we have to add another agent. Vitamin E, this is interesting because vitamin E is an antioxidant, and in patients without diabetes, it actually has shown that it helps fatty liver and in NASH, where there's inflammation. However, when vitamin E was studied in diabetic patients, it did not show improvement. So sometimes these patients come to us and ask about the use of vitamin E. So as we understand now, vitamin E is helpful to prevent liver problems and treat liver problems in non-diabetics. But if we have a patient who already has diabetes, it will not hurt them, but there is no benefit when vitamin E was studied in a dose of 800 international units in diabetic patients. So non-diabetic patients, vitamin E, and I've seen this used by liver doctors quite a bit in NASH and fatty liver. But for diabetics, it's not going to hurt them, but it's not going to be helpful based on the information that we have at this time. And the dose is 800 international units. So go back to the case. If you remember, obese with a BMI of 35, with right upper quadrant pain, with some NASH. The ALT was high and the AST they were both normal, but the ALT was higher than AST. So when you're talking to this patient, we discussed weight loss. We set up a target that, look, this is how much you need to lose. 10%, 12% is where you will start to see the most benefit. Talked about Mediterranean diet, blood pressure control, and exercise. And exercise will not only help with the weight loss, but it will also help with the NASH indirectly as well. So this is the question. The patient was only on metformin. So what is the second line of second line therapy after metformin and management of hyperglycemia? So we have talked about these agents. So this is Victoza, This is our Trulicity. This is Jardiance, DPP4, which is sitagliptin, and pioglitazone. So these are some of the choices that we can pick up an agent from. So as we understand things now, Victoza, which is liraglutide, and Actos are the two agents that if we add these agents to our patient regimen, we know that there will be clinically there will be clinical improvement in our patients' fatty liver and NASH. The other agents have not been studied, especially SGLT2 or Jardiance has not been studied yet. Maybe it will help, but we don't have that information yet. And of the GLPs, of all the GLPs, liraglutide is the only one that has been studied. But if you think about it, the dulaglutide, which is your Trulicity, with weight loss, this will also help. So GLP class is a good agent. Pioglitazone, which is Actos, it's a very good agent, but again, the concerns of weight loss, weight gain, and fluid retention and bone loss are there. So if you have a very young patient who does not want to take an injection, and we know he is at risk, he or she is at risk for developing NASH because of the obesity and other things, with diet, with weight loss, maybe pioglitazone or Actos may be a good agent for these patients, and we should give our patients that option. All right, so the case continues. The patient asks you, he's concerned about using atorvastatin. The patient is on atorvastatin. He has read on the WebMD that it causes liver issues. So should he continue his atorvastatin or should we stop it? Now, this is very important. Most patients, even if their liver enzymes are slightly elevated, they are very concerned about using a statin. So unless and until your liver enzymes are very high, threefold above the normal limit, we should recommend, because it's going to help not only with their cardiovascular disease management, but also with the NASH and fatty liver. So the answer is they should continue. We're going to continue to monitor with weight loss, follow the liver enzymes, but we should not stop statin in this situation. And this is important. We always should think about bariatric surgery as an option, because it will help with the weight loss. It will help with the lipid profile as well. It really is a metabolic surgery. And this patient that we had discussed, BMI was more than 35. And if you have a BMI of more than 35 with complications from obesity, NASH is one of the complications. The fatty liver is one of the complications. If they have diabetes, obstructive sleep apnea, significant arthritis, which is resulting from obesity, then those are indications for bariatric surgery. So yeah, so that is always an option to discuss with the patients. I think there are two things I wanted to discuss before I end this discussion. Is the good news is we have other agents coming out. Ozempic, which is your semaglutide, is available in a higher dose with the name of Wegovy, and this can lead to about 17% weight loss in 3 to 6 month period. So this is really exciting. It will be available next month, I think. It will be, right now our dose of semaglutide is 1 milligram. It will come out in a 1.7 and a 2.4 milligram. So our patients with obese patients who are at risk for developing fatty liver, this may be a very, very good option, because as you can see here, the weight loss, it's achieving the weight loss which you need to prevent the progression of the fatty liver. And this is the last slide. There is another medication that will be available, I think, end of the year. This is a twin incretin. So there are two incretins mixed in this. So normally when we are giving Ozempic and Trulicity, other things, this is only our GLP or glucagon-like peptide. This medication, tirzepatide, is actually a combination of GLP and a GIP. So two incretins combined together. And this is just some phase 2 data on these here. So the weight loss is quite significant. A1C change is significant, and weight loss compared to, so the red is your Trulicity, and this blue here is tirzepatide. And if you can see here, the weight loss is quite significant compared to a GLP. So these two incretins, when mixed together, work really well. So we have a lot of options for our patients. And I think we should develop a systemic approach in identifying and then talking to these patients and then eventually treating these patients. So that's all I have. If you have any questions, I'll be happy to answer.
Thank you so much, Dr. Heder. That was a wonderful presentation. It's such complex information, but you do such a wonderful job and like breaking it down into understandable terms. So I know that's difficult to do. So I truly appreciate that.
Thank you.
Did anyone have any questions, comments, or thoughts that they wanted to share with the group? Feel free to unmute or chat in.
I was wondering when you spoke about the more sensitive testing outside of doing the ultrasound, what are like your normal requirements for getting that covered by insurance? Do you know?
Yeah. So, normally, unless patient is significantly bothered by it, I'm more interested in preventing it. If I'm concerned that the liver enzymes are high, I'll probably send them to the hepatologist because they have more. I will do an ultrasound. That's a bare minimum. I will do the ultrasound. I will check their albumin, liver enzymes, repeat it again one more time. If they're drinking, stop it. If they are on any medications that is affecting it. I will get an ultrasound. But the other testing like CT scan or MR, spectroscopy, I will leave this to for the GI doctors. Because I know that if I'm giving them the right medication and they're losing weight, I'm already treating the condition. And then some cases, they will require a liver biopsy to see if there's inflammation or fibrosis taking place. So at that time, rather than me trying to order a test, I will send them, but I will start the treatment. I will start, if I have any index of suspicion, then I'll start the treatment, which I think will be more helpful for the patient. But to answer your question, liver function test, repeat it, looking at their medications, and then doing a liver ultrasound is a good start in my view.
Okay. Then one other thing with the pioglitazone, whenever they've already been diagnosed NASH or NAFLD, what is your risk versus benefits of starting that with a patient that already has osteoporosis? Are you more likely to go with something like Ozempic?
Yeah, I agree with you. Now, but I will give these two options to the patient. Now, if the patient is reluctant or does not want to use the injections for any reason, although it's as you know, this is just a once a week injection, so most people are very comfortable. So in my view, if you give them both the options, most patients overwhelmingly will prefer a GLP-1 over an Actos. So that is my experience. And again, in an elderly patient who has osteoporosis, then she's at risk for other problems as well. Your congestive heart failure and other things. If any patient for any reason does not want to use an injection, that as long as they understand the risk factors, which is congestive heart failure and stuff, that may be an option. But most patients, again, hands down, they want to use a GLP. Sometimes we can combine the two together. We don't have to pick one or the other. So if we do a GLP and then now they're losing weight, or the GLP may offset some of the effects of the Actos, but that will be in a young male, like in the 40s, mid 40s, 30s, if they're developing this problem. I will not probably do it in a 60 or 70-year-old female patient.
Okay. And do you see with Rybelsus, do you see the improvements? I know it hasn't been studied as well, but.
That is right. Yeah. So oral semaglutide has not been studied yet. Now, in my view, I will have Dr. Giordano talk about this as well. Oral Rybelsus, semaglutide is really, the weight loss is less, the benefits are less. It has to be taken in the morning. You cannot take thyroid medication with it. The cost is an issue. If they're just taking one injection a week, then my patient can achieve everything that an oral medication will give them. So plus, again, it has not been studied. And the weight loss is there, but not as robust as it is with the injections. And especially with the higher doses coming out, like we discussed, I think the market and for oral Rybelsus or oral semaglutide will continue to shrink over a period of time.
Thank you.
You're welcome.
And Sarah, I noticed you had unmuted. Did you want to ask a question or comment on anything?
I was just wondering if you had noticed, because I've been using a lot of GLP-1s over the last year, which I had not done previously, but I've actually seen a little bit of elevation of people's LFTs with this. And I was just wondering if you have seen any of that.
LFTs. When you say LFTs, you're talking about.
I'm sorry, they're AST or ALT, and honestly, it's usually both, and just modest. Still less than 100, but You get them on the statin, you get them on the GLP-1 and some metformin and 15 to 20 elevation.
Yeah. No, I have not, but I will advise you on these patients, you continue to trend them, as long and see what happens over a period of time. Because if they are losing weight, then they should continue to come down. But if it continues to rise, then sure, looking at some of the other medications, maybe their alcohol consumption history, other things will be more helpful. And again, the ratio, the ALD, AST, if the AST is more higher than the ALD, then that suggests medication or alcohol or some other culprit.
Great, thanks.
Mm-hmm. But we normally do this medication in PCOS patients who are obese, young females. And from my experience, I've noticed, PCOS, again, because of insulin resistance, can cause elevated liver enzymes. And when we start this, the liver enzymes do come down with weight loss, though. They have to have the weight loss.
Excellent. Any other thoughts or questions?
That was great. Thank you so much, Adnan.
Oh, thank you. Thank you, Jennifer.
Elizabeth, was there a question or comment?
Can someone have normal fasting glucose levels and still be insulin resistant?
Yeah, so pre-diabetes, can, like we saw, notice in that slide, at the earlier stages. So if they have pre-diabetes, borderline diabetes, or they have just insulin resistance on exam. So it's just that they have not announced that they have diabetes or pre-diabetes yet. They will eventually. So identifying these patients, obese patients, high BMIs, sedentary lifestyle, I think that can put them at risk, yeah.
And that would be like metformin is usually required at that point as a intro.
Again, if you're targeting weight loss, metformin is a good start. But again, starting some of these agents with diet and exercise. So diet and exercise, and if they're still struggling and they continue to gain weight, then I think you can intervene with GLP, for example, which is an ideal agent for them.
Alrighty. Any other comments, thoughts? All right, then. Well, thank you so much, Dr. Heder. This was an awesome session. We're hoping to get some more cases in the future so we can get presentations and stuff, but implementing the case within your didactic is always nice. So I appreciate that.
Thank you.
So my only announcement for today is, so July 14th, we're actually canceling our endo session. Elizabeth and I and Jay, we're doing our Super Hub training. So we're going to be busy all week that week. So unfortunately, we have to cancel July 14th. So the next time we'll all meet is July 28th. And Dr. Heder is actually up to present again on introduction to adrenal diseases. So keep an eye out for that reminder. In the meantime, if there are any cases or anything you all would like to address in the next session, just shoot us an email and we'll make sure to have it. So thank you all so much. We'll see you guys next time.
Hi, everyone. Thank you so much.
I think